Hi everyone. Today we are going to continue by talking about penetrating injury to the neck, and this is just essentially a patient that gets stabbed or a patient with gunshot injury to the neck with violation of the platysma muscle of the neck. So that is penetrating injury to the neck. There's usually violation of the platysma muscle, and what I'm going to say is that it still follows in the normal ATLS algorithm management, right? The airway, the breathing, the circulation, disability, exposure. You want to check for the airway. The airway is patent. You know, if there's airway compromise, you want to place in your endotracheal tube, mechanically ventilate the patient, assist the patient with the breathing. Then next, you want to evaluate for the heart signs of either the vascular compromise majorly or injury to the other structures. We have to have it at the back of our mind that an individual with penetrating neck injury typically will have compromise to three major structures. Number one, the vessels, particularly the arteries, the carotid in the neck, the subclavian in the neck, the the airway, which is the tracheal, the bronchial walls, and of course the esophagus. So think about these three things: the tracheal, the esophagus, the vessels. We group the trachea and the esophagus together, then separate the vessels. Yeah. So we have to evaluate for the hard science during our premise survey, and that is embedded within the acronym NEAR. So the NEAR, the hard doesn't start for anything, it's just to make it meaningful. The N is talking about neurologic deficit. So there is penetrating injury to the neck, there's a gunshot wound, and there's damage to the carotid vessels, not supplying blood to the brain again, stroke-like presentation, difficulty moving the arms, difficulty moving the legs, sensory deficit, right? Expanding hematoma. There's an expansion, of swelling because of blood collection within the neck space. There's active bleeding, either from that, puncture site or, in form of hemodynamic instability, hypotension, tachycardia. Those are hard signs of arterial injury, and you need to resuscitate that patient immediately by securing the airway and driving the patient to surgery for exploration. Very, very important. Very, very important. If the patient has neither of these, no heart signs, no hemodynamic instability, the blood pressure is still okay, the patient is alert, right? Order a CT angiography of the neck to look at the patency, if there's any compromise of the vessels of the neck. If you find anything, you need to immediately do a surgical repair or embolization. So aside the artery, you can also have violation of the tracheal, the esophagus, right? We have said this, and majorly the way they present is that you are going to notice um, evidence of subcutaneous emphysema, which I know we are very familiar with. There is going to be soft tissue swelling within the upper part of the chest, right? Swelling within the face, and we are going to have features of crepitus, right? You can see some bubbling within the wound, right? Some bubbles from the wound, and of course gurgling breath sounds. All this is just talking about hair tracking into those tissue spaces. So because you are suspecting injury to the tracheal especially, or injury to the esophagus. So esophagus, when the patient is now having additional dysphagia, difficulty swallowing and the likes. So you might do your bronchoscopy to look at the airway, the trachea, the bronchial wall, as well as oesophagonoscopy or oesophagram, a barium swallow, to look at the esophagus. So don't forget, you can do a direct visualization of the tracheal or the esophagus by doing bronchoscopy or esophagoscopy. Or for the esophagus, you can use your barium swallow imaging, right, to which is a oesophagram. So to look at the esophagus. So don't forget, look out for the hard signs of arterial injury. If you don't find any, order your CT. If you find any, wheel to theater, surgical exploration. For the tracheal or the esophageal, compromise, do your direct bronchoscopy or your direct esophagoscopy, to evaluate for any injury to this area. So we have said it. Wounds that violate the platysma muscle are considered as a true penetrating neck trauma. Why the superficial wounds, you just do a conservative wound care. That is all. So for the chest, same thing as the neck, ABCD approach, your primary survey, your secondary survey, and you might have some additional, added situations in the question stem. Maybe they tells us somebody had chest trauma, was stable initially, and suddenly start deteriorating. You know, the pressure start falling, the blood pressure start falling, the patient becomes tachycardic, there's elevation of the JVP, right? Maybe they had one or two ECG features, RBB block, right heart strain, you consider anterior embolism. So even if we don't have that, that should be the first thing that will run through our mind if there's a sudden, because anything sudden stuff, and you are thinking of chest injury, it is air embolism, it is PE, you know, from the hair, you know, um, that is what you should pick. Um, so an individual with chest trauma that was initially stable and suddenly deteriorate, hair embolism. Or we have a patient with chest trauma, and part of the findings we see maybe from our survey is what a new diastolic murmur, right, which is suggestive of aortic dissection. The aorta has dissected and that affected the integrity of the aortic valve. So there's now aortic valve insufficiency. So we tend to experience that diastolic murmur, right? So if there's a diastolic murmur after the chest injury, think about aortic valve regurgitation. And most commonly, they like, showing us this stuff a lot. You are thinking of there's a patient had a chest trauma, and on maybe your examination, um, you notice maybe there's a hemothorax, and you place in your chest tube to drain, the blood there. But you notice massive hair leaking into that chest tube. The hair leak into that chest tube is massive. Think about an additional tracheobronchial injury. Once you see massive hair leaking into the chest tube, that is tracheobronchial injury we are talking about. So, you have to do a surgical exploration of that patient. You need to do a surgical repair. There's no way about to go about it. So massive air leakage into the into the tube drainage, the tube thoracostomy. Think about tracheobronchial injury. Very common. Please have this at the back of your mind. Please, massive air leakage, tracheobronchial injury. New diastolic murmur. Of course, we are familiar with this. AR, aortic regurgitation. Sudden deterioration after being initially stable, hair embolism. So if anybody has an object impaled, stuck in that area, leave it there and go and do your surgery. Please never pick removal or dressing of the injury by removing the. Please take that person to surgery, because that object left inside to exert a tamponading effect on that area. Because once you try to remove it, you can dislodge clot. You can even, you know, you know, rub, you know, disturbs the hemostasis that is already happening at that area, and there can be massive blood loss. So the best thing is to leave that impaled object and take the patient to the operating room for treatment. So during our evaluation, you have to order a chest X-ray, for patients with the chest trauma, because there are so many things you can find, and I have the acronym DATE to remember. Of course, there's high chance of, in pneumothorax, open pneumothorax, tension pneumothorax, pneumothorax. Sometimes you might not find them doing your premise of it when you start doing your, secondary survey, or your investigations within your secondary survey, that you are now going to see some of those things. So, in addition to finding pneumothorax, which are the commonest stuff that you find, it's very common. You puncture the chest, there's hair entry into the pleural space. It's very easy. Or blood collection within the pleural space. Very easy. But in addition to these, you can also have date. Date. The D for the diaphragmatic. The diaphragmatic is not very, very common, but you can have diaphragmatic tear. You can have aortic disruption. You can have tracheo brachial, injury. So the T is talking about tracheal, the tracheobronchial injury, and he is talking about the esophageal injury. So you can see all these on your chest X-ray in addition to the pneumothorax or the hemothorax, right? So it is very, very common, particularly when the chest injury is, at the level of the nipple. So if it's at the level of the nipple in between, there's a very high chance that it's going to affect the mediastinal structures which are there. So the heart and its great vessels, the tracheal, the esophagus, you know, all those structures that are there. So you need to do imaging to look at each and every one of them. So if the patient is stable, right, you need to order echo to look at the heart. If there's any, puncture to the heart, you need to look at the great vessels that are also emerging from the heart, like the aorta. So you need to order a CT angiography to look at the aorta and its branches. You need to do bronchoscopy to also look at the upper airway, particularly when you notice the patient is having stridor, having hoarseness, features of subcutaneous emphysema. Think about the injury to the upper airway. So I forgot to mention that when I was talking about tracheobronchial injury, hop. So the hoarseness of voice, the inspiratory stridor, the features of subcutaneous emphysema, the crepitus. Think about upper airway injury, order your bronchoscopy. And of course, when you have the phageal too, you know, also think about ordering for the esophagogram or the esophagograph to check for the esophagus. So don't forget. So you'll have done your normal premise survey, um, try to detect any abnormalities within the respiratory, tract. Sometimes you might not detect it until you do your imaging, your secondary survey. And part of what you can find in your chest X-ray is what the pneumothorax, the hemothorax, and in addition, you can find the date, the diaphragmatic, injury, the aortic rupture, the tracheobronchial injury, as well as the esophageal, compromise. So here we have to pay attention. The treatment is very important. We are already familiar with the treatment for pneumothorax and hemothorax. Just place in your tube, right? Just do your tube thoracostomy, and you drain out whatever collection that is there. But you also need to pay attention to the collection. Very, very important. So if the initial output is about 1,005, so that is massive hemothorax, massive pneumothorax, or output of 300 mils per hour for 3 hours. Either you drain 1,5 at once, you drain 1,5 or more at once, that is massive. You drain 300 mils per hour for 3 hours, that is massive. Some texts will also tell you you drain 200 mils for 2 to 4 hours. It's also massive. So just have those values at the back of your mind. So 1,5, 300, per hour for 3 hours, or 200 per hour, for 2 to 4 hours. It's massive, you know, um, hemothorax or pneumothorax, and you need to do an operative thoracotomy. So you are not going to stop. So once you do your tube thoracostomy, you might need to follow it up with operative repair if you have a massive collection. 1,5, 300 mils, for 3 consecutive hours. Of course, any injury to the date, will also require surgical correction, aortic repair, diaphragmatic repair, esophageal injury, tracheobronchial injury. You need to treat all of them with your surgery. So you might also need to do what we call immediate thoracotomy. You are just trying to make a small um, incision within the chest, to be able to assess the heart and do maybe like an open cardiac massage, especially in individuals with penetrating injury to the chest with cardiac arrest. So the pulse is no longer there, the patient is not breathing. You can quickly, and you know that it's because of the penetrating injury to the chest, so you can quickly do that immediate thoracotomy, make a small incision, get to the heart, and do a open cardiac massage. So it can help. It's if the patient has a tamponade, you can quickly relieve the tamponade. You can also try to apply some pressure to assist with the pumping activity of the heart to increase the cardiac output, as well as also take the patient out of cardiac arrest if you relieve whatever is causing the arrest from your evaluation. So Next is abdominal injury. So please don't forget, what we have talked about with respect to um um the chest injury. It's commonly tested. Think about the hemodynamic status of the patient first. Is this patient stable or not? That is the first question you must always ask yourself. If the patient is not stable, you know that this is definitely going to be surgically repaired. If the patient is stable, then you might start evaluating depending on the presentation, right? So, the patient having hemothorax, pneumothorax, based on the percussion notes, which we have done our recipe. So you do your tube thoracostomy, right, to drain out the collection. But depending on the volume of the fluid, if it's very large, 1.5, you need to do, an operative, thoracostomy, to get in and explore and see whatever is there. And again, you might also need to evaluate for damage to additional structures like the aorta by doing your CTA, the heart by doing echo, you know, the tracheobronchial tree and esophagus, depending on the presentation of the patient. So the abdomen can also suffer penetrating injury, right? And what you are primarily concerned here is about violation of the peritoneum. Is the peritoneum violated or not, right? And it can come from gun injury, from gunshot wound, stab, knife, and the like. So majority of the gunshot, about 98% of gunshot injury usually violate the peritoneum, right? Usually violate the peritoneum. So um, during your evaluation, just to summarize everything, you have to follow the ATLS protocol. We are not going to keep running through that, every time. So we already know that. When you are moving forward with your evaluation and you are assessing for peritoneal signs to check if there is violation of peritoneum and you are able to identify them, that is automatic indication for surgery, right? The features of peritoneal compromise, the guarding, the rigidity, the rebound tenderness, they are present. You need to do a surgical exploration. Surgical exploratory laparotomy. Very, very important stuff, especially when the gunshot injury is below the nipple. We have said it, above the nipple is chest, right? Above the nipple is chest. So that's when you be doing your echo, you be doing your CTA of the vessels within the aorta, your bronchoscopy, your oesophagonoscopy, right? But if the injury is below the nipple, it's already getting to the abdomen, right? So in that instance, you are not going to be picking um thoracotomy, right? So it's going to be exploratory laparotomy. So pay attention because sometimes they talk about these landmarks in the question stem. Very, very important stuff. Below the nipple, abdomen, above the nipple, in between the nipple, chest, right? So check for the peritoneal signs. When there's peritoneal compromise, that is an heart sign. Another heart sign is hemodynamic instability. So everything that is constant for everything. Hemodynamic instability, tachycardial hypotension, the peritoneal signs, extruded bowel momentum, so heavy visceration. You see the bowels moving outwards. They are just outside. I've seen this once, during my house job, from gunshot injury. And the patient was even a Jehovah Witness, so it was a little bit hard for me that night. So bowel evisceration, mental evisceration, peritoneal signs, hemodynamic instability, and I have it here, impalement. You have the knife stuck there, bam, or the wood that they used to puncture the abdomen is there, bam. You need to do a surgical exploration of that patient without removing that impaled object. Very, very important. So, but if you don't have any of these, the patient is stable, the patient is alert, no peritoneal signs, no evisceration, what you are going to do is that you are going to keep that patient, observe that patient for 24 hours, right? You observe the patient for 24 hours, and what do? You just monitor the vital signs and you do your blood work. Very easy. So the blood work we are doing is just more like full blood count. You are checking for the level of the red blood cells, you are checking for the white cell count, and you are also doing your clinical examination to check for your hemodynamic instability and peritoneal signs. So within 24 hours, you keep observing, and if you notice um, a drop in the white blood cell, a drop in the red blood cell count, the hemoglobin drops by 3 milligram per dl, right? That is significant. That means there's still an undergoing bleeding. Maybe there's a retroperitoneal bleeding or bleeding somewhere that you don't know. So, or evidence of leukocytosis, like, I mean, there's like an infection, you know, from damage to the peritoneum or, you know, an abdominal collection or something, right? Um, Then you also check for the peritoneal signs. So if there is guarding, there's rebound tenderness, there is rigidity, you know, you also need to do a surgical exploration of that patient. You also assess the hemodynamic status, there's hypotension, is tachycardia. You find that within 24 hours, you need to perform laparotomy. But if the patient doesn't have any of this within 24 hours, you just discharge the patient goes home. So yeah, so that is it. But if you notice any of this, leukocytosis, drop in the hemoglobin count by 3 milligram per day, or peritoneal signs, hemodynamic instability, you have to do your laparotomy. So we can see that it's very, very easy. So just have the heart signs at the back of your mind. Anything short of the heart signs, observe. You don't need to do any um, imaging per se. Just observe. Just do your clinical examination as well as your hematological, you know, evaluation. Then the last is the extremity. So somebody suffers penetrating injury to the extremity, had a knife injury to the extremity, or there is like gunshot injury to the extremity. So you are scared of the vessels being destroyed. You are scared of the nerves being destroyed. You are scared of the muscles being destroyed, right? So you think about the soft tissues, the muscles. You think about injury to the bone. You think about injury to the nerves as well as the vessels. So those three things are what you are practically concerned about. And most individuals with the extremity injury usually have, you know, multiple injuries being present with them, right? So so we have said it: the soft tissue, the bone, and the neurovascular. So for the neurovascular, so picking the vascular component, you want to start assessing the pulse of that extremity. Let's say the leg. So you start palpating for the dorsalis pedis, the posterior tibia pulses, if you can feel them, right? If you can feel them strong and good, fine. If you can't feel them, then you need to evaluate. So what we should do next is to do the ankle brachial index, the ABI, right? So the normal value should be between 0.9 to about 1.2 or 1.4, depending on the reference value. But anything less than 0.9 means like there's a compromise of that vessel. You need to follow it up with imaging. You need to follow it up with imaging. So practically the best imaging to pick is your CT angiography. But sometimes some of them have some conditions that might not allow them to do CT angiography. Probably they are pregnant, or maybe they have contrast allergy, or they have renal impairment. So if you, or maybe the CT angio is not even available, so just pick the Doppler ultrasound. So the Doppler ultrasound can help evaluate both the arteries and the veins. But the best after your ABI is less than 0.9 is to go for your CT angiography. So, but if CT cannot be done, you do your Doppler to evaluate for hemodynamic compromise, right? And for the neurovascular compromise, you also want to check for the motor and sensory function. So you examine. So can this patient feel pain? Can he feel pressure? You know, check if the patient can move the legs, can move the arms, right? That particular extremity that's involved, just to assess for the integrity of the nerves, right? Um, then we also have to keep, you know, at the back of our mind, the hard signs of vascular injury. It's just same as what we have said for the neck one. So when we are talking about the neck, the near, it's just that here we are not picking the neurologic deficit as, you know, a hard sign. So neurologic deficit is placed under the soft sign for the extremity. So the hard signs we have to, you know, put at the back of your mind. Yes. The hard signs we have to put at the back of your mind is um expanding hematoma. So the patient having expanding hematoma, having pulsatile bleeding, having abscess pulse. So you try to percuss check for the integrity of the pulse. It is absent. You see that there's an expansion of hematoma blood collection within that area, or the bleeding is pulsatile. So you know that okay, these are hard signs of vascular injury, and you need to do a surgical exploration as soon as possible. You know, um, hemodynamic compromise, expanding hematoma, pulsatile bleeding, absent pulse. You need to do a surgical evaluation. But if it's just soft signs like neurologic deficit, like maybe the bleeding, we were just told that the patient is having significant bleeding on history or the pulse is weak, just do your CT angiography and you move. So please don't forget, after you do your ABI, if the ABI is the option, pick ABI, right? Particularly for the legs, pick ABI. If it's not there, pick your CTA and you move, right? But if you are seeing anything about heart signs, absent pulse, expanding hematoma, pulsatile bleeding, you know, blue, having a blue due to maybe a fistula formation. Once you see blue in any question, that patient should do a surgical repair as soon as possible. Yeah. So that is that about the neurovascular. Then the orthopedics is talking about the bones. You might need to fix and reduce the bones and the like, but there's an approach. So the first is to go from the strongest to the weakest. That's where I see it. So the strongest is the bone, then down to the vessels, then down to the nerves, right? The strongest is the bone, the vessels, then the nerves. So um if the bones are broken, you need to fix and reduce them, right? If the arteries are compromised, you need to revascularize, right? You need to do an arterial repair after you have done your bone repair. Because if you do your arterial repair before you do your bone repair, there's a high chance that those jagged bone will still, tear the arteries. So you have to fix the bones first, reduce the bones, do your revascularization of the arteries, repair them, then approximate the nerves together. So you start from the bones, go to the vessels, then down to the nerves. Um, if there's any form of amputation, like what I mean is maybe that's not the best word, like when there's separation of a particular appendage from the body. So you have to preserve the integrity of that appendage. You have to place it in a gauze which is soaked with saline. Then you wrap it within a plastic bag and you ice it so that you can reduce the metabolic activity, and there's a reduced metabolic demand, reduced need for oxygen, reduced need for metabolism and the like, so that you can still keep it alive and sustained for a while. So because if you don't do that, the viability will drop and there's a chance of death of that particular tissue you are conserving. So um, just look out for anything like this in the option, talking about wrapping in gauze, soaked in saline, kept in a plastic bag, then hiced, right, for separation of a particular part of the body. And of course, um, you need to give prophylactic antibiotics, right? You need to give prophylactic um, tetanus, toxoid, and for wounds that are contaminated, you need to irrigate, you need to debride, then you do your surgical repair when necessary. So you can have some complications, and part of the complications I've used style to mention it initially, and that's the arteriovenous fistula, very common in penetrating injury to the extremity, the thighs, the legs, the arms. You can have the force that is sharing off that artery, leading to high blood flow, high blood leakage from the arteries. It can that high flow can also puncture into the vein and establish a connection between the artery and the vein, leading to arteriovenous fistula. So you are going to see in the question stem the painting. We are going to see the examiner's painting stuff like the patient having a continuous brew, right? You can see a palpable trail, a continuous brew. That is arteriovenous fistula. Sometimes they can also have pseudoaneurysm, but that is very common. People that undergo like catheterization, maybe they want to catheterize the heart and they are going to the femoral, vessels. You can have a pseudoaneurysm in which you have blood collection being conserved within the periconnective tissue of the artery. So that one, you are not going to see a continuous brew. So it's only going to be a systolic brew. So watch out for that. If it's systolic brew, it's a pseudoaneurysm. So that means that it hasn't got into the vein. But if it's a continuous brew, it has extended to the brain and there's a fistula formation. And we already know that when there is a fistula, it means that you are directly shunting blood from the artery to the vein, bypassing the capillaries. And, it means you are not getting to the capillaries, you are not getting to the arteries, right? And that is where you have the highest peripheral resistance. So it means that you have little resistance being encountered and you are just having blood being, shunted directly like from the heart, from the aorta back, to the heart. That's just the way it seems. So you are overloading the heart and it's going to lead to high cardiac output failure because the resistance is just there to like slow down, you know, the speed at which the blood is flowing. But if there is no resistance encountered because you are bypassing the arteries, it means that as you are pumping blood into the vessels, the arteries is going back to the veins directly, right? So the heart is going to be working tirelessly, and at the end of the day, it's going to fail because of the high output, and we are going to start seeing signs and features of congestive cardiac failure. So this is very straightforward, very very straightforward stuff. I know all of us will know this, so it's just like a reminder. Just think about the algorithm for the repair from the hardest to the smallest. So the bone, the arteries, and the nerves. So talking about post amputation pain, right? So sometimes you might need to amputate people with orthopedic injury, particularly if you are not able to attempt your resuscitation within 6 hours. So there's injury to the limb, there's bleeding everywhere. You are not able to revascularize the artery. Within 6 hours, you are unable to reach out to the vascular surgeons, and there's an eventual compromise of that vessel. There's gangrene of the legs, necrosis, and like you need to amputate it. So, um, amputation comes with some complications, right? And the first thing I want us to know there is DVT. Of course, if you amputate a leg, you are not going to be using that leg as actively as the other leg that is intact, right? So there's a high chance of stasis and the likes, and of course the bilateral triad bleeding. I said bleeding, clot formation setting, and DVT. So this occurs in 50% of patients with lower extremity amputation. They have DVTs. Stump hematoma is another one. The initial amputation, the vessels, some of those vessels too can be kind of severed, and you have like Hocquart collections of blood, forming hematomas. So this is very very common in people that are using antithrombotic agents. So anticoagulants, and there's easy chance of bleeding, and during the surgery you just have blood collection around that covered area because the stump is going to be covered by skin, right? So you can have collections, more like seroma kind of thing, right? And the blood will just collect there, and if they are not properly drained, it can lead to stump hematoma. Stump pain is another thing. Stump pain, so DVT, stump hematoma, stump pain. And stump pain comes from three basic stuff. Either there's infection from the surgery, there is neuroma formation, or there is ischemia. So if you know, severe particular part, of course, blood flow to that area is going to reduce, right? And ischemia is actually with pain. Part of the cardinal features of ischemia is pain. So, because of the reduction in blood flow to that area, there is pain from the ischemia. Sometimes when you sever a particular limb, you are going to take out the nerves. You are going to take out the vessels. So if you take out the nerves, there's a high chance of the nerves regenerating and they are sprouting. So regeneration of the nerves can actually get entrapped within the scar tissue from the healing process. And if you have entrapment of the nerves within the scar tissue, it can lead to neuroma, which is usually very painful. So neuroma formation, like few weeks, few days after surgery, can few weeks usually can lead to pain. Neuroma is very 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 painful. So you have to inject some local anesthetics to that area to numb those nerves and reduce the pain. And of course, post-surgical site infection. So infection at the area of the surgery, you know, if not done cleanly, or sometimes infection happens inadvertently, even from hematoma. If you have collections within that area, they can breed, you know, infection, and the infection will lead to inflammation, which will lead to pain. So think about ischemia, think about neuroma, think about infection. For the pain, we have explained neuroma. It's just like a localized pain to that area. you know, and you can block it with your anesthetic um, injection. So um, So if you notice that, okay, there's no feature of ischemia, the pulses are okay, right? No cardinal signs of infection, and the patient is having pain, think about neuroma. Think about neuroma. Infection is another one. You can have infection of the graft, the skin graft covering that stump. You can have infection of the bone, right? Osteomyelitis. Then phantom limb pain is one thing they commonly like asking, and this is a diagnosis of exclusion. So it means that you will have ruled out neuroma, you will have ruled out ischemia, you will have ruled out infection. So this person is having phantom limb pain, and the pain is kind of classic. It is, of different variety. It can be burning, it can be shooting, it can be aching, it can be electric type, electric shock sensation, it can be, you know, um, aching, it can be shooting, it can be tingling, it can be burning, you know, that's one thing. And you will have ruled out the other three causes of pain, which is ischemia, neuroma, infection, they will be absent. Then you can say that the patient is having phantom limb pain. And how do you treat? Now, the pathophysiology of phantom limb pain is just that you have amputation of a leg. Um, if you try to move that particular part, you cannot move it, right? It's not moving, right? That kind of sends some visual and proprioceptive signals to the brain that you cannot move it. And the brain is going to interpret that as absence of that area completely, right? And it brings about upregulation of the NMDA receptor within the associated tissues, leading to increased pain sensation. So it's just more like increased sensitivity of the somatosensory cortex, like interpreting pain signals, you know, directed to that area of the amputated limbs. So we are not trying to move any stuff here. The most important thing is just to know that it is due to heightened sensitivity in the brain. That's number one. And number two is that it's because the brain is not getting visual signals that you are moving that part. That is it. So that is what scientists are now trying to mimic to reverse the condition. So what are we now doing? The first thing is to give some agent. We already know that it is due to upregulation of the NMDA receptor. So why not give NMDA receptors antagonist, right? Ketamine is an example. Give ketamine, it helps. It is going to block those nociceptive pain signals to the brain because they work through the NMDA receptors. Give neuropathic, pain relievers, the gabapentin, you know, the local anesthetics, lidocaine, and TCA, tricyclic antidepressant. So your TCA can work, gabapentin can work, lidocaine can work. Of course, when you say anything related to neuropathic pain, you must not forget gabapentin. That is impossible. Like, if you don't know anything, pick gabapentin. You are going to be correct. So NMDA antagonists like ketamine, the neuropathic pain relievers like gabapentin, amitriptyline, lidocaine, right? And the other treatment. So you might not find any of this drug. Sometimes they might put this other treatment. And the first is mirror therapy. So mirror therapy is just that you are trying to place a mirror in between the legs. You are covering that amputated area, and that mirror is going to show as a reflection, is going to show the reflection of the other interlip. So let me show you an example of what I have. So this is what we are talking about here. This is the leg of the individual that is intact, right? You can see the doctor standing next. This is a mirror in between the legs. We can see that the mirror is showing a reflection of this leg. Yeah. And this person is going to be told to look at that mirror, right? The amputated leg will have been covered, so you will not see that. Then um the person looks at this leg, tries to move the intact leg, is going to cause like a movement within the reflection, right? The brain is going to see that as, oh, this limb is back, right? It's going to reorganize the neural pathways that have been disturbed, and it will minimize, the pain. That's just it, because the initial cause of the pain is because the brain is having, a feeling that you are not moving that leg, right? Leading to changes within the neural circuitry and upregulation of the NMDA receptors. So the brain is going to have a perception that, okay, the limb is back. Visual perception, visual proprioceptive perception, that you can move it from one place to another place and you can see it that is moving, right? So the brain is going to be tricked. That is it. It's going to be tricked, and there's going to be, down regulation of those receptors and reconnection of the neural pathways, leading to suppression of the brain. That is mirror therapy. You can also do transcutaneous peripheral nerve stimulation. So you can just stimulate the peripheral nerves within that area by applying some electric current. It can also help to suppress the nociceptive signals that are there. Visual reality. Visual reality is just all those things that they wear to the face and they try to see things. So you are just going to create like a visual impression that the individual is having the two limbs, right? You are going to show imagery of the individual having the two limbs, walking, moving, doing stuff, right? So that one works similar to mirror therapy. We are going to try to reconnect, you know, redistribute the neural circuitry that has been established and, deceive the brain that you have, you know, gotten that leg again, gotten that particular body part again. Or um, you are trying to distract the brain to focus on the reality experience. Maybe the person is jumping, moving up and down, and the brain is going to focus less on the processing of the pain signals. So over time, it's going to reduce the pain stimulus. So that's how it works. The peripheral nerve stimulation, the visual reality, mirror therapy, NMDA antagonist, the gabapentin, and the like. So we come to the end of penetrating injury. Thank you.